Today we're going to talk about hospitals, and when you talk about hospitals, it's important to understand kind of what they are now versus what they used to be. So, a hospital, when most people think about it, they think about the emergency room or a place when you go and you're sick. But in general, hospital is an institution for the care of the sick. Now, excuse me. There has been a little bit of transformation lately where places called urgent care centers have arisen. And these facilities are kind of hybrids between doctor's offices and hospitals where you can go for emergency type care, but more basic. So a lot of stuff that you could go to the doctor for, or that you would go to the doctor for, but you don't want to wait. You can go to emergency care. But in general, that's kind of the hybrid, the middle ground between the two, hospitals and doctors. But when we talk about hospitals, early on, they were charity centers that were run on donations. And the other thing early on was that hospitals tended to be very specialized, and they specialized on specific types of cares. Recently, over the past couple decades, hospitals have really transformed. And they are now what are called health centers, and they encompass a large variety of types of care. So, for example, they have inpatient surgery, outpatient surgery, emergency care. They do some home health. They do nursing centers in some cases. You go to hospitals to give birth, maternity, all that. So hospitals have really evolved over time. Now, just as everywhere, whether it's a for-profit or not-profit, they need money. They need money to come in. And the sources of revenue have changed over time. And so I just talked about how they used to be run primarily on charity. Then as insurance got bigger, as Medicare, Medicaid were enacted, it's really shifted around a lot. Now, when we look at today, if we look down here, we can see that a bulk of it comes from insurance. So 36% from private, 29% from Medicare, 20% from Medicaid, 7% from other government, and then you have philanthropy and patient self-pay. Now, before we get into the ways that they get paid, the thing I want to point out here in particular was that this patient self-pay of 3%, if you recall back to early on in the course, in the earlier lectures, I talked about how overall healthcare out-of-pocket is only 11%. So, okay, well, 11% is healthcare as a whole, but only 3% for hospitals. So why is that? What tends to happen with hospitals is that your bills are much, much larger. Because hospitals are where you get a lot of expensive procedures, like surgery, like emergency room care, like staying overnight, inpatient care. And with all that, the bills are very high. Most people who have insurance, however, have a deductible. So there's only a certain amount they pay up to, and after that, the insurance company may pay 100% of that, or 90%, or whatever it is. And so, with that, if you have a $100,000 bill, and your deductible is only $1,000, right? In that case, your out-of-pocket is only 1%. So that tends to be the case with hospitals, where you're paying a lower percentage out-of-pocket. If we go back here, and we talk about the sources of revenue. So these are the ways that hospitals get paid. They have money coming in. Philanthropy and grants, that was very big in early medicine, but not as big now. Excuse me. Today, philanthropy, grants, charity, a lot of it is used for either construction or research. So a lot of times if hospitals want to expand, they look for donations. If they are trying to do some research, they look for donations or grants from the government. Now, what ends up happening in a lot of these cases is that these grants could go wherever they want. you could give $100 to the hospital for child cancer research, but in the end, it's really up to them how they want to allocate it. Having said that, it's usually in the hospital's best interest to put the money where they say they're going to put it. Because if they don't, right, there's going to be a trust issue. They're not going to be able to get donations from people down the line, and so forth. So that's one way. That's one source of revenue. Another one is what's called a global budget. And this is when there is one budget that is given to the hospital to cover all, or most, if not all, their expenses. These are more commonly the case when you talk about state-run hospitals. And the reason why is that with global budgets in general, you tend to have it where these hospitals that are getting it don't have a normal revenue flow coming in. So they tend to not have money coming in from the patients, or insurance for that matter. And so examples of where you're going to see global budgets is going to be state mental hospitals and military hospitals, as two examples. So and the next one, charges. That's a charge for a specific amount for a procedure. And this is similar to how primary care physicians are paid when we talked about physicians. Per diem is a setup with per day payments. So every day the hospital gets payments for one reason or another. The cost reimbursement, we talked about this with physicians as well, but with cost reimbursement, that's actually the hospital getting reimbursed for what it costs to treat a patient. Now, as we've talked about at different points, there is a difference between charges and cost reimbursement, where charges is what actually gets charged to the patient, where cost reimbursement what it actually costs to treat them. And there's a gap here a lot of times. And that gap is patients being charged more to help pay for uninsured patients that the hospital's taking a loss on, if there is research done at the hospital, if there's teaching done. Now, on top of that, the hospital also needs a recoup for people who work with the hospital who are non-revenue generating employees. And by that I mean they're doing things that is not treating the patient or doing anything that has the patient or the patient's insurance provider paying the money. This can be like the maintenance staff, it can be clerical, billing, security, all that. All right, so again, there's that difference between charges and cost reimbursements. What's becoming a little more popular, especially in recent years, is DRGs, which stands for Diagnostically Related Groups. This is payment based on patient diagnosis, not treatment used. And a lot of times what happens is if a patient is, for example, admitted to the hospital to get an appendectomy. All right, they have an appendicitis, their appendix needs to come out. The hospital is going to get one set amount for all services they do leading up to and including the surgery and then until the discharge. Now, if there's other things that happen with that, it could be a different circumstance, but in general, it's based off of that. Now, the goal with this is to cut back on overcharging, doing things that aren't necessary. Capitation has been discussed a few times. It's a per-person payment per person per month, regardless of the number of visits. And then there's just other managed care contracts which may come up between the insurance company, or agreements between the insurance company and the provider. So that's the revenue side. If you look down here, just the ones we talked about before. But again, a lot of it comes down to from insurance, but it's how they're paid. Okay? Because most hospitals are the case where they're not state-run, they're not run by the government, and so they're not getting things like the global budgets or something like that. So most of their money is coming from insurance, either from private or the government.